Howland is the epidemiologist with the Illinois Department of Health, and she, as we said in the introductions, is joined by Mary Driscoll and Sandy Anton. So we're very glad to have you all on the call. And so Julia, I'll go ahead and turn it over to you.
Okay, thanks, Emily. So thank you, everybody, for joining us this afternoon. This presentation that Sandy and I will be giving today really comes out of the work that we've been doing with our communities as part of the ASTHO Million Hearts Project, and then also, as Emily mentioned, in collaboration with many other states, some of whom are on this call, to develop an algorithm and a way of thinking about discharge data that is effective and useful for communities in identifying high-risk hypertensive groups and controlling that hypertension. So we're very pleased to be here with you today. We also just want to recognize Jeff Doherty, who was an intern who worked with us quite a bit on this project. So we appreciate his efforts on this as well. So just as a bit of background, we came to this project and we view this data analysis as part of a collaborative effort between our ASTHO Million Hearts Project, obviously that's why we're here talking with you today, and also as part of the Community Transformation Grant Healthy Hearts Project, which is what Sandy and I started with working in these two communities. So as part of the Healthy Hearts Project, we're actually pulling data from the primary care clinic's electronic health records to identify hypertensive patients from the clinical record. So we viewed this use of discharge data as a way to complement the data we were pulling from primary care clinics' electronic health records. So we're working in Macon and Peoria counties. For those of you who aren't familiar with Illinois, those are counties in the central part of the state. And one thing, when we were planning for our grant and planning for our ASTHO Million Hearts work, one thing we thought that we could bring as the Illinois Department of Public Health, and in particular as the Division of Patient Safety and Quality, was access to the hospital discharge data. So we here at the Division of Patient Safety and Quality are the folks who collect and analyze and release that data. So we thought that perhaps our access to that data and use of that data would be an asset to the communities, and so it's something that we thought very early on about how to use that in our Million Hearts work. I think one thing that the discharge data brings that other data sources maybe don't is that it is current data. So we receive data with a delay of approximately 6 to 9 months, and it's not sample data. So that's something that sets it apart from data sources like UDS data or behavioral risk factor surveillance system data, or even the data that we're pulling from primary care clinics. I mean, those are all subsets of a population, whereas the data that we receive from the discharge data is every single discharge that happens in a community or in a state. And I think in particular when we're looking at counties like Macon and Peoria that aren't huge population centers, they both have mid-sized cities in those counties, but they're not huge cities. I think the use of non-sample data is really excellent because we're very used to seeing unstable estimates of burden of conditions like hypertension in smaller cities. And I think it can be frustrating for communities to try to plan programming or assess effectiveness of programming when they don't have stable current estimates of burden or a way to evaluate efforts that they've been undertaking. So I think especially when we're looking at smaller population centers, non-sample data is really has a real place. And then another reason that we were interested in looking at the discharge data in particular was that we think of hypertension as a condition that could and should be controlled in the outpatient setting. So when a patient is being seen in an emergency room or worse yet in a hospital, in an inpatient hospital setting for a condition like hypertension, it really represents probably a failure of the primary care system or access to the primary care system in controlling that patient's hypertension. So it means that we have patients who are really sick with a condition they shouldn't be really sick with, and also it means that we're devoting a lot of resources in terms of healthcare spending and also in terms of patients being out of work, being unable to participate in their normal activities because of a condition like hypertension. So it really represents the far end of the spectrum and in my mind, an opportunity for the patients who need our help the most. So those are some of the reasons we got interested in looking at discharge data in the first place. Just a brief word on our methodology. We looked at the 2012 Illinois hospital discharge data records as part of this analysis. I assume most people on the call are familiar with the discharge data, but we here in Illinois receive basically a complete record of the patient's hospitalization. This includes demographic information about the patient, information about the patient's payer, information about how much was charged to the patient's payer, some information about the sort of procedures the patient underwent as part of the hospitalization, and also information about the diagnoses the patient received. We receive up to 25 diagnosis codes per patient. They are in ICD-9 format. And we applied this discharge data to PQI number 7, which is the hypertension admission rate. I think the reason we were interested in using this rate in particular, and it goes back really to what Emily was saying earlier about our work with other states in the ASTHO Million Hearts Collaborative, is that we wanted to be able to share the data with our communities in a way that they could compare to other communities in the country. So we wanted a nationally recognized measure, a nationally recognized algorithm that would allow them to compare across communities and to other states and other communities elsewhere. So that was the reason that we tried to identify something that had been vetted and used elsewhere. But we did modify this measure slightly. The most important modification is that we decided to apply this measure to outpatient cases as well. So to cases in which a patient was treated in an emergency room and then released without being admitted to an inpatient facility. So that was the most important modification. We also chose to include patients who were transferred from one hospital to another. In the original algorithm, those are excluded. And I won't get into the reasons there unless we have a question about it, but that was a choice we made. So I'm just going to now show some examples of how we shared the data with the communities. This example here shows a graph of the rate of inpatient admissions for hypertension, where hypertension was the primary diagnosis in the patient's record over the 4 quarters in 2012. So you can see here that it's just a rate for the entire county over the course of the year, and allows the county to see that their rate is rising, although probably not significantly. So this was the first kind of graphic representation of what we were able to share with the communities. We also shared these sorts of charts with them. These charts obviously show the incident rate, the standard error, the lower confidence interval, and the upper confidence interval for our 2 target counties, and then also for the state. I thought that this was an important chart to share with the counties because it allows them to start to understand some of the instability inherent in this data, so they can see the wider confidence intervals, and they can also compare their rate in a quarter to the state, for example, and see if it is or is not significantly different given the confidence intervals. And I think this is an important thing to share if people are interested in doing this kind of work in their communities, because there is some risk in using something like discharge data for a condition like hypertension because the data is relatively unstable unless you have a large population center you're working in. But I think sharing this kind of thing was very effective because counties could see the instability and understand the limitations of the data, but still I think they found a lot of value and worth in it. But this, I think, in light of being a responsible steward of the data and sharing this data responsibly and clearly, I think this is important to share. This graph just shows the rate, similar to the first graph I showed, among outpatient visits. So these, again, are treat and release emergency room discharges for the same county. We found that counties were very interested in understanding both inpatient and outpatient discharges. So I think showing these separately was useful for our communities. They really felt like these are different patient populations and that they could be approached in a different manner. We found quite a bit of interest in the communities we've been working in to demonstrate the payers that were the primary payers on discharges for hypertension. And I think this is important for a couple reasons. The first is that, of course, payer serves as kind of a proxy for socioeconomic status and allows communities to target particular socioeconomic groups or age groups. If we're talking about Medicaid, self-pay, and Medicare patients. So I think that that's interesting. And then also, if they're talking to legislators or they're talking to payer groups, this really allows them to demonstrate some true impact or need. They can say, 38% of the patients who have a primary diagnosis of hypertension have Medicare as a primary payer. So, Medicare would have real stock in interventions to help decrease hospitalizations for hypertension. So this sort of graphic I think was really useful for our communities to consider. This shows the same information, but again by inpatient. And the reason I'm showing you this is because in my mind, I'll just flip back here to outpatient, you can see that we have Medicare rate of 38%, and then for the inpatient visits, Medicare jumps up to 55%. So in my mind, this is a good demonstration of why showing inpatient and outpatient data separately is useful, because the experience of the patients, the demographics of the patients affected really are different. And then this, I think, was probably the most popular or useful thing we did with the data. This is a map of Macon County, and it is broken down by zip code. And we are showing here the rate of inpatient visits by zip code in each of the zip codes in Macon County. And people were very excited by this, very interested in this, and in some cases, in some of the counties, very surprised by the information we found. So I think that when counties and communities are planning for targeting interventions or targeting outreach efforts, this kind of information is very helpful to them. They can see where the biggest problems are in their county and really target efforts to those communities in particular. Another note on this is if people look down at the lower right-hand corner of this map, you can see the legend. And you'll see that especially that third category, the highest rate category there, it has a very wide range of 109 to 540 cases per 100,000 population. And so that's a huge range. And that speaks, again, to the instability, especially when we're dividing the data by zip code. These rates come to be very unstable. But I do think that there's a responsible way to report this. And so I was very careful to group all of those highest rate zip codes together in the same color so that we weren't identifying one zip code as the absolute highest rate when perhaps there weren't actually very many cases there and it was just an unstable estimate. So I think doing things like only including 3 groups in a map and trying to keep highest rate groups together and not draw attention to one zip code in particular is a good way to address some of the instability issues. So we've had quite a bit of interest and success around the use of the discharge data for our communities with the ASTHO Million Hearts work. There are some, I think, exciting and important next steps we have planned. The first is that we have, you might have noticed that I have some slides from a different county included in this presentation. So we do have many more communities that are interested in this data and excited about seeing this data for their counties and their communities. So that, I think, is the thing that speaks most to our success, is that we have a lot of interest and people are wanting to get engaged and work with this data in a similar way. So that's the biggest next step. The other thing that we are working on right now is, as I mentioned all the way through here, we have only applied this algorithm to the primary diagnosis spot in the discharge record. We are interested in applying this algorithm to all 25 of the diagnosis spots in our discharge record and seeing how that changes things. Obviously, it would increase the stability of some of our estimates, give us some more cases, but there are some problems that perhaps we are not getting an accurate sample of all hypertensive cases if we include all discharge codes. So we're interested in looking at that and seeing how it compares. As I mentioned, people are very interested in the issue of payers and charges. So we are considering how to best and most accurately and usefully demonstrate and use the charge data we have available to us. We are working now to learn and apply some new software tools here at the State Health Department to help us identify patients who are being seen in the emergency room frequently or more than once in a short period of time. And we would like to work with our communities to identify these patients and make sure that they have good access to primary care and try to address some of the reasons why they might be frequently visiting the emergency room. So that's another thing that came out of these conversations, is that our communities are very interested in trying to reduce this utilization of the emergency room for conditions like hypertension. And so we hope to be able to use the discharge data to identify frequent users of the emergency room and connect them with appropriate primary care. And then I think the next step that we would like to do is we here in the Division of Patient Safety and Quality are very concerned about social determinants of health and identifying disparities and addressing disparities in our communities. And so we're thinking all the time about how to capture social determinants of health in our data analysis. So we are working now on calculating rates by payer rather than just showing percentage of payer. We would like to be able to identify a rate by payer to find the highest risk group by payer. And then also having an overlay of poverty measure from the census data that appears on the map as well might help to identify some of those social determinants of health. So these are some of the things we're interested in doing in the future with this analysis. So I think now I'm going to turn it over to my colleague Sandy Anton, who's our project lead, and allow her to just finish up the last couple of slides here.
Thanks, Julia. And it is just quickly 2 slides. It's been interesting. We wanted to share with everybody the impact of this data. Julia mentioned earlier the importance that we've seen of integrating this data with other data systems. This is not intended to be a standalone data source. We are truly looking at it as part of our toolkit of data-driven change. And it's important to realize just that. It's not going to drive everything. It has to be part of the package. What we're seeing, though, in addition to that, is that the use of this data and our epidemiologic expertise is driving an ongoing relationship with the Department of Public Health, kind of cementing that relationship, and it's actually encouraging other counties to participate with us. Once they understand the depth and the richness of this resource, they're very interested in how this can actually support the work they are currently doing. This is helping all counties that we're talking to identify new groups or geographic areas to target. It's helped a couple of our counties actually drill down to specific zip codes in which they want to conduct some focused interventions on hypertension screening, management, and maintenance. It's been very helpful from that big picture perspective. And as Julia said, everyone is very accepting of the data instability, the fact that it's small numbers in some cases, but they're nonetheless finding it very, very meaningful to their local application. Julia, can you forward for me, please? And then a few lessons learned, very high level here. Everyone wants more data. The minute we show them data, they want more analyses, they want more overlays, they want a different angle, and it just shows how hungry people are and the value that the Department of Public Health can bring to the table. We've been kind of pleasantly surprised at how the presentation does matter. Julia mentioned that maps have been very impactful, has both validated and surprised some of the counties with what the data showed against their perceptions. So the presentation is very, very important. And we've been pleasantly surprised at how much the local health departments and the clinicians, the clinical providers, do value the state-level data. They see it as an adjunct to the data they have with their particular population they serve or their particular local service area. And as mentioned, how important it is that this discharge data can either refute or validate local assumptions. It has indeed created quite a few discussions and actually stimulated some work in the direction of how do we target populations. And again, using this data has helped us be an objective driver for local collaboration. They look at this, the health departments and the providers are looking at this data as outside of their local systems and therefore more objective, and it's helping to bring people around the table. So With that, I will turn it back over. Julia, any conclusions from your side? There's our contact information. We're very glad to hear from anybody. Julia, anything you'd like to add?
No, I don't have anything at this time. I do see we have some questions. Emily, would you like us to address those now or wait until after both presentations are completed?
I think you can go ahead and address those now.
Sure. So we have two questions in the chat box there that I see from Robin. Robin, when we do, so one of the questions is, when you state outpatient on your slides, do you mean just ED? If not, what else is included in outpatient? So we here in Illinois do receive data from several different sources in an outpatient setting. So we receive data from outpatient imaging centers, outpatient diagnostic centers, ambulatory surgery centers, and from the emergency rooms. So we don't receive data from outpatient clinics or outpatient physician offices at all in our discharge data. So in this case, we really do mean emergency room, but we say outpatient because there are other other sorts of services that are being reported in the outpatient discharge system. So but to answer your question, yeah, we really do mean emergency room in this case. And then how would we capture the mapping of poverty? So if people are interested, we actually have done quite a bit of work with mapping here in Illinois. There's the Illinois Public Health Map, if people want to Google that and take a look at some of the other work we've done. But we often just lay an overlay of rate of poverty over a community. So for example, showing the rate of poverty in a county, and then under that showing rate of a disease or burden of a disease in the county. And so it helps to sort of think about both issues at the same time. In the same map with hashing or something like that, you can show both poverty and rate of disease. And of course you see that there's quite a bit of overlapping and co-occurrence of high rates of poverty and high rates of disease. And so we aren't saying that the disease is occurring within the same patients as are being seen for hypertension, but just that we're able to look at both where there are high rates of poverty and where there are high rates of disease at the same time. I don't know if that answers your question.
Yeah, it does. Thanks a lot.
Yeah, sure. So that we get that, we get that information from census and other sources like that.
Okay, thank you. Yep.
Okay, great. Well, thank you so much, Julie and Sandy. That was a really great presentation, and it's very clear that there's a lot of interest around this type of data, both with your local partners and at the state and national level. So I think with that, we'll move on to Marilyn's presentation. So I think Vanessa and Sarah, if you're presenting, Vanessa Walker-Harris is the Medical Director for the Maryland Department of Health and Mental Hygiene Center for Chronic Disease Prevention and Control. And Sarah Barra is an epidemiologist of the Family Health Administration at the Maryland Department of Health and Mental Hygiene. So I will turn it over to both of you, and just let me know when you want me to advance your slides.
Sure, thank you. We are conducting Million Hearts in Maryland, and if you'll advance to the next slide, please. Just to give you sort of an overview of what we're doing in Maryland as far as our ASTHO project is concerned, we are coordinating with our internal programs and external stakeholders to maximize the region impact of Million Hearts. Really, we're looking to identify, control, and improve hypertension. We are engaging multi-sector partners in our target jurisdictions, and I say target because for this project, we couldn't work with all the states, but we chose some very select areas in very different geographies and populations to really see the impact of Million Hearts in different areas. And we did that. We wanted to enhance community clinical linkages and facilitate quality improvement projects. We implemented a learning collaborative, which has been very successful to date. We've really had a lot of participation, and that's been fantastic. And finally, we've been doing a lot of PDSAs, including those focused on data, and so that's actually going to be our focus for this presentation, is really taking it through a particular PDSA for our data. So if you can go to the next slide, please. Just real fast, these are our implementation sites in Maryland in red. So we have Washington County in western Maryland, Cecil in the upper right-hand corner, Baltimore City in the center there, and then St. Mary's County in the southern part of Maryland. So you can see very different geographies, different populations. So we're getting a lot of different impacts with. If you'd go to the next slide, please. So as I said, we thought we'd take you through one of our PDSAs on data just to show how we're using this process to help shape our data and our decision-making process. So we agree with Illinois that hypertension should be controlled in an outpatient setting. So we are looking at ED cases only. We really didn't want to get into the inpatient because we felt that was sort of too far down the road for the impact of this particular project, given the short time frame of the project. So we're looking just at ED cases, and we really wanted to, we need to determine a methodology for measuring Maryland resident ED cases reporting hypertension. And just a caveat, we're able to talk about Maryland residents in Maryland hospitals. We weren't able to get data from other states, surrounding states, so if they go to another jurisdiction, we wouldn't be able to capture that. But given that these are ED cases and not inpatient, we felt like that was okay. And then we also wanted to obtain a baseline number of resident cases reporting hypertension, both as a primary diagnosis and any diagnosis. As Julia said, for Illinois, they had 25 diagnoses. In Maryland, we have 30. So we really wanted to see it both as the primary diagnosis of the main reason why they're at the ED, but also as any diagnosis to capture those coming in for other things, but also having hypertension, which may be contributing to their primary diagnosis. And so in addition to doing this for the state of Maryland to really have sort of a state baseline, we are doing these analyses for our partner jurisdictions, which are the 4 counties in red that we highlighted earlier. Could you go to the next slide, please? So as far as our doing, we actually did an initial ED data analysis. We did determine baselines for Maryland and all of our counties. But then if you go to the next slide, we found some things that were a little funny. And so part of really going through our data to understand what's happening, and again, this is 2012 baseline data, we found an issue where not all coders were correctly coding county of residence, which was rather interesting because not only does that determine the county you're in, but it actually determines if we consider you a state of Maryland resident or not. So that was a rather interesting finding. And what we ended up doing is working with our partners at the HSCRC, which are the primary owners of these data, to redefine residents based on a zip code algorithm, which was found to more reliably code. It was more reliably coded in the beginning. You're more likely to have a zip code than you were a county entered in, actually. And then using the algorithm, we could place them within a specific county. Even though zip codes cross lines, by using that algorithm, we were able to get them into the county where they belonged, and hence giving them the correct county of residence. So if we go to ACT, that's kind of where I was leading to. Can we go to the next slide, please? Thank you. So we redefined how the definition of residence, and we adopted that. So we now are moving forward with the data owners to make sure that there are more quality assurance protocols in place to make sure that data that we are receiving are data that are both accurate and reliable. So that was a rather interesting process for us as far as a PDSA, and I think was very helpful in making sure that we had good data to present for this project, and not only this project, but for other projects within our health department. So if we could go to the next slide, please. So progress to date. So we have our brand new data set with more accurate residence variables, which has to make at least us at the state very happy, and also those at the county. So we have created baselines for using 2012 data, and that's something that we are working on for 2013 for the quarters leading up to this project, and then with the remaining quarters in 2013 actually starting, to look at what does ED data look like within the intervention period, and that's something that we'll continue to work on through this project. We also have created a hypertension algorithm. It is actually slightly different than what Illinois did. We also started with the PQI-7, but we decided to make it more broad. The idea being that the PQI-7 excludes those who have other cases or other conditions such as heart failure, and we felt that they should actually be included in our ED definition because we felt that providers can intervene with all patients, even those with heart failure, and that was a decision made with our clinical staff as well. We did adhere to some of the exclusions of the PQI-7, including those who are under the age of 18. We excluded our transfers from other acute hospitals or EDs just because we felt like you should be counted once and not, twice. We also excluded non-Maryland residents. As we said, we were solely concerned with Maryland residents because that's our population with whom we're intervening. And just as a data point, we had talked about the county of residence being a little hanky, and so we got that clarified. But we were amazed to see that the records had age, gender, almost all of them had race. So a lot of those basic demographic characteristics were all entered, which is fantastic because if you have a lot of missing data, then it really makes you wonder about what analyses you can and cannot do. So you could go to the next slide, please. So finally, some next steps. We are looking at 2013 data currently. We are really interested in seeing the trend chart to show what our baselines, including those quarters, look like prior to this intervention, before this program, and what it looks like during and after the intervention, to really be able to tell the story of Million Hearts and if it did in fact have an impact on the ED data. We are also interested in mapping hotspots for ED visits within counties. This would be done at the zip code level, and that's something that we'd want to do in terms of doing it both in rates, because you do want to be able to compare, so there would be age-adjusted rates, but we're also wanting to be sure that we have some actual numbers behind them just to ensure that people who maybe are not, in their data realm understand that, these cases actually, they can actually go and count the number of cases. They can actually go and reach out and touch them. So I think that makes it more real for them if they're not, if the rates seem a little fuzzy or out of reach or that sort of thing, that actually having numbers to go along with rates makes it much more applicable. So finally, just some lessons learned. We felt that the PDSA process was really a great way to frame our data discussions and to document how we were able to move through this process and to show some of the changes and actions that we did. And I think we're going to continue to work with our partners and keep on sharing what we have and I guess taking in their input and being able to provide specific data as they need. So does any of the rest of the Maryland team wish to add anything? Okay, I think that's all we have for Maryland.
Great. Okay, thank you so much. I think we can open it up for questions now for either the Illinois or the Maryland team. So if you have any questions, feel free, don't forget to unmute yourself, and then feel free to chime in with any questions. Let's see, Paula, I don't know if you're on the call at this point.
I am. Can you hear me?
Yes, we can
okay,
hear you.
I'm sorry.
No, that's okay. I just wanted to invite you at this point if you have any questions or thoughts on these presentations.
Sure. Yeah, one question that I do have is actually around, I actually have a few questions, but this one is around workforce. And I'm wondering, in Illinois and Maryland, as well as in other states, if you have the epi and biostat staff who really understand the hospital discharge data, and in Maryland and Illinois, did you have to do any kind of training or really delve into the data to begin to understand it, or is this something that you've been doing for some time now and you really understood it already?
So from Maryland, we've been working with these data for a number of years. So we were able to really dive in, though we, like I said, with the PDSA, we're rather surprised with some of the findings and possible QA issues that we found. But generally speaking, we've been working with these data for a number of years.
This is Julie from Illinois. I would agree with what Marilyn said. Our division, the Division of Patient Safety and Quality, is actually the division that is responsible for the discharge data here in Illinois. So it's a data set that we're familiar with and work with for many different projects.
Discharge data, have you had any challenges around getting access to this data?
This is Vermont. We use hospital discharge data on a really regular basis. Our biggest challenge at this point, we have very porous states when it comes to hospital care, and some of our neighboring states are a little bit behind in getting us data. So sometimes our biggest problem is that we're limited to only including in-state hospitals, and we can't speak to the 1,000 or so people that every year are leaving to go to a hospital on the other side of a river. But for the most part, I think we're pretty well versed in the use of discharge data.
Great. And you don't have any barriers accessing it other than the interstate issue, or do you have other challenges as well accessing the data?
We don't get, so when we get our data files, we get all of the hospitals at once. So I think Illinois was saying they got a quicker turnaround. Our hospitals are a little bit slower. Also, the way the mandate is set up, they have to get it to us within 6 to 8 months or something, and by the time I can actually get my hands on it, it's usually about a year. So that would be one barrier, but for the most part, there's been a system in place for us for a while that seems to be working.
And just to be clear, this is Julie in Illinois. We don't get interstate data either. It's just that we don't. We have. I'm sure we have some patients who are leaving the state, but we don't consider that to be a huge loss of patients here in Illinois. And this analysis that we presented here today was really only for Macon and Peoria counties, and I don't think residents from those two counties would be going to another state to receive care.
Yeah, and here in Vermont, we know that at least 20% of our population goes to a hospital in New Hampshire, let alone the number that go to Baltimore or Massachusetts. So for us, we know that that's a barrier we're always addressing.
Yep.
I'm wondering how Maryland deals with that. I live here in Maryland, and I know we're bordered with 5 states. So how do you deal with that crossover to other states?
So we do have access to some other surrounding states' data, and so that is very helpful. I think someone made the comment that it's oftentimes behind, and so we found that's the case for us. We only have access to the inpatient from other states. We have not been able to access outpatient data from other states. Really, we have an idea of where they're going, particularly with those that surround D.C. We know that there's a fair amount of traffic going from those 2 counties specifically into D.C. We know that for other counties that are on the border with other states, that they will go to larger cities such as in West Virginia and Delaware, especially for inpatient. But we also know that the way that the ambulance runs are, they'll most likely be staying within Maryland if they're being picked up by an ambulance. So for ED data, we're figuring the ED data, it means it's an emergency that you're traveling to the nearest hospital, and generally the nearest hospital is within the state, except for those counties that surround DC. However, none of those counties that are directly touching DC are in our Million Hearts Collaborative. So we understand it's there and we understand it's a limitation, but for this particular project, it'll be less of a limitation than others, is how we are thinking of it at this point in time.
Well, I guess I'll just ask one more. The issue of timeliness has come up and how quickly data is available. And I'm wondering for your PDSA cycle for hospital discharge data, what is kind of your best case definition of timely data? Is it 6 months, 9 months, a year? What are you considering good enough, or not good enough, but gold standard rather, for your PDSA cycle?
So in Maryland, we are very close to having access to 2013 data, and once we have that, that last quarter, that quarter 4, is the start of our intervention period. So we are very happy to have that, and then from there, we are still working with the data provider to see exactly how timely it can be. Is it 6 months after it's collected, or that sort of thing. We certainly expect no more than a year, but we are also cognizant of the timelines of this grant, and so we are working to the best of our ability to meet those timelines as we can.
And here in Illinois, the data I presented today is 2012 data, where we would also be happy to work with 2013 data to show our communities. But the way that we thought about this data analysis was less as a way to assess or evaluate the ASTHO Million Hearts work, and more as a way to direct it. So to give a baseline to communities and to find populations or zip codes or areas of the county that are particularly high burden. So, I think that we're dealing with, as I said, like a 9-month delay, I would say, with data. So I don't know that it's such a good data source to evaluate such a short project as the ASTHO Million Hearts project. In my mind, a better data source for us for that kind of purpose is the data we receive from the electronic health records at the clinic, because that can be as fast as yesterday's data. And so that's a much more responsive data system.
In general, do you feel like you need a more responsive data set to measure interventions, not just this intervention, but interventions other interventions you have going, or ones that you may have in the future?
Well, I don't know about need, but it's certainly helpful, and it seems to be something that the clinics and communities really respond to.
I'm asking really from a personal point of interest, because I was involved in a conversation with CDC on Friday, and they were saying, well, hospital discharge data is good enough. Survey data is good enough. We don't need immediate data for chronic disease. And I was just wondering to hear other people's perspective other than CDC, people who are actually working boots on the ground.
Yeah, well, I think my perspective on that, and something I feel like I'm always saying on my Epi soapbox here, is that we have to get to a place where we're using existing data systems better. So I think one advantage of a data system like the hospital discharge data is that it's data that clinics are already reporting. So rather than asking them to report into another system, fill out another form, it's data that's already existing. So in my mind, that's another huge advantage of it. Although there is a delay, it's not a duplicative effort for them.
Great point.
And we in Maryland certainly agree with that point, and we're also looking to other ways to find data that are more instantaneous than these ED data, because we do understand the limitations of that. We are looking at local health information exchanges, and we're really, part of our Million Hearts efforts are looking at working with clinics, working with EMRs, getting those EMRs connected into health information exchanges, which then be connected into our state information exchange, which already has hospital discharge data in it, and hospital data are starting to become more and more available. We're trying to get, the state are trying to get more clinicians and systems plugged into this so that we can have that more breadth and depth of data in a much quicker time frame.
Great, thank you. I appreciate that a lot. Emily, do we have any other questions coming up in the dialogue box?
No other questions in the chat box right now.
Okay. Any other questions, burning questions that people have that you'd like to ask?
This is Emily with ASTHO. One question I had for both Illinois and Maryland, and then of course for anyone else on the call. Julia with Illinois had touched on this briefly, but sharing this data with partners, it sounds like, at least in Illinois, there's been a lot of interest with the local partners. And you'd also mentioned the possibility of sharing it with different payers and Medicare, Medicaid as being useful information for them to have. Has anyone thought about other partners that might find the information useful or helpful to them? And the second part of that question is, have you reached out to them or talked with them to find out in what format that data would be useful?
This is Julie in Illinois. So I mentioned that we have a lot of interest from community groups, from local health departments, from clinics. I think the other group that is probably, Sandy can probably speak to it more, but I think we have quite a bit of interest from the hospitals that are in the target communities we're working in. The limitation we have there is that we do have strict rules about sharing hospital-specific data outside of the agency. So that's been a challenge, I think. But I think that would be another group that we know is interested, and I think probably the format they're interested in is seeing as much patient-level data as possible, so seeing patient names or dates of discharge or other reasons the patient was being seen, that kind of thing.
I have had a couple conversations with one of our large payers in Illinois, actually with the Blues, and they're interested. I don't know where that interest is going to go as far as data presentation or activities or anything, but we just started some discussions at that level.
All right. Well, Paula, I don't know if you have any other questions or thoughts for the group before we wrap up, or if anybody has any last thoughts or comments.
I think I've asked all my questions.
Great. All right. Well, we will wrap up just a couple of minutes early. Thank you so much again to the Illinois and Maryland teams for presenting today. And thank you, Paula, for facilitating the discussion. That was really, I think, rich and interesting to hear the perspectives from everyone. And thanks to all of the rest of you for participating. So following this call, we'll send out the notes along with a recording of the call and the webinar slides to all the attendees. So you can look for an email with those materials. And then we'll also be posting a recording of the presentations as well as slides on our new peer group call webpage. So Katie Potestio has done a great job of creating a webpage as part of our After a Million Hearts webpage that lists the archived recordings for all of the peer group calls to date. So feel free to pass that link on to anyone who may not have had a chance to register for the call or was unable to attend. And the link for that webpage is on the screen now. So if there's nothing else, thank you so much for your time. I hope you have a wonderful afternoon, and I'm sure we'll all be talking again soon.
Thank you.